if you will, somebody.
Good morning, everyone.
Second one.
Welcome to the House Healthcare Committee. Sorry for the delay in starting. So this morning, we'll be talking about suicide prevention. We're going to start with the Department of Health, and Department of Mental Health is here as well. And then at 10:30, after we take a little bit of a break, we will have some providers come in and talk to us as well. So welcome, Caitlin. And I think since many of you are new to our committee, we're going to do a quick introduction so you know who you're talking to, and then I'll turn it over to you to start.
Okay.
So Bobby, do you want to start?
Bobby Fardes Rubio. I'm from Barnet and I represent Waterford and Reigate, Caledonia 1.
Alan DeMar from Enosburg, representing Enosburg and Montgomery.
Ryan Sheena from Burlington.
Alyssa Black, Essex. Stumbling over my own name.
Lori Houghton, City of Essex Junction.
And I'm Topper McFawn. I represent Barrytown and part of Williamstown.
Mari Cordes, Lincoln, Bristol, Moncton, and Starksboro.
Daisy Rebecca, I represent Winooski.
Leslie Goldman, we have 3 Rockville, Westminster, Brookline, which is the Bells Falls area.
Peterson from Clarendon, represent Clarendon, Wallingford, West Rutland, and a piece of Rutland Town.
And we have, I'm going to let you introduce yourself as well.
Okay. Dane Whitman, representative from Bennington, and I serve on the Human Services Committee.
And Dane, please feel free to ask any questions as well. We just raise our hand. I'm going to turn it over to you, Caitlin.
All right. Well, good morning, everyone. Thank you for inviting us to speak with you today. Nick and I are really excited to speak to you. My name is Caitlin Quinn. I'm a public health analyst at the Vermont Department of Health. I've been with the health department since 2018 and have been working on suicide prevention data full-time for the past 2 years. I have a lot of passion for data, and specifically for data that illuminates the issue of suicide here in Vermont. I do want to recognize before we get started that behind all the data I'm about to show you are real people, people who have struggled, people who have suffered, and people who have lost their lives to suicide. I utilize and share this data to show the burden of suicide and self-harm in Vermont and the toll it takes on our neighbors and friends. I offer this data in hope that it will help us in our quest to reduce suicide here in Vermont. I'm also joined here today with my colleague, Nick Nichols, who's joining virtually. He is our suicide prevention grant coordinator at the Vermont Department of Health. He will speak to some of the suicide prevention programs and activities we are doing here in Vermont before we turn it over to our friends at the Department of Mental Health.
Right. And Nick is joining us by Zoom, so we can't see him right now, but we'll have him come on. And Nick, if you're out there, if you want to jump in, just please do.
Hi, everyone. Thank you for asking me to join today. Can you hear me okay?
Yes, we can. Nice. Thanks for coming.
Okay, so today's data will focus both on suicide morbidity and mortality. This slide I've included to illustrate the burden and scope of suicide in Vermonters. So this pyramid shows those who struggle with suicidal thoughts or behaviors, self-harm, and people who have attempted or passed away from suicide. At the top of the pyramid, we have the number of lives lost each year to suicide in Vermont. On average, we see 122 suicide deaths a year. As we move down the pyramid and look at our morbidity data, you see that the numbers get larger. In 2018, approximately 1,900 Vermont adults attempted suicide in the past year. On average, we see 1,000 hospital visits for intentional self-harm. And for those of you who don't know, intentional self-harm is doing something intentionally to yourself to inflict pain or suffering. There may or may not be intent to die. We also see on average 4,900 or 4,800 emergency department visits a year for a suicide-related reason. This graph shows the trends of suicide deaths over the past 10 years, from 2012 to 2021. The blue dot is the rate of deaths for Vermont residents. Rates here are expressed as per 100,000 residents. The orange dot shows the rate of deaths for the United States, and the green bars show the number of suicide deaths in Vermont over time. So there's a few key takeaways from this data. The first is that Vermont's rate of suicide death has increased over the past 10 years. Vermont's suicide rate is higher than the US and has been every year for the past decade. And in 2021, Vermont saw a record, both in the number and the rate of suicide death. You will notice here that there is no bar for 2022. That is because there are still a number of death certificates that are pending. We do know, however, that through the end of October, we have seen 108 deaths due to suicide, which is a little bit higher than what we usually see through that calendar month previous years. So the 3-year average through October is 108. In 2022 through October, we have seen 108 suicide deaths. So
Go ahead, Elsa. Do we know how many death certificates are still pending?
Jen, do you
I
know?
believe there were like 35 or 40 earlier this week, pending for 2020.
And pending suicide, pending death certificates may or may not be suicide.
Right.
Yes, that was my question.
Yeah.
What does pending mean?
Yeah, it just means they haven't been assigned a cause of death. They're either still being investigated. A lot of times for those deaths, they're waiting for toxicology to come back and things like that. So they just haven't been given a manner.
So hold on 1 second. Can you just state your name for the record? So that's okay.
I'm Jennifer Hicks. I work with the Vermont Department of Health, and I manage one of the statistics units in the Health Statistics and Informatics Division.
So that means that those are still under question. It's not like someone had a heart attack that you're worried about. They're just deaths that are due to self-harm or some kind of questionable. I mean, can you explain that more?
So the pending death certificates are deaths that have not yet been assigned a manner or cause of death. So they're still being investigated by the person that is writing the death certificate.
It could be a heart attack.
It could be a heart attack.
It could be anything.
It could be anything.
No, that's what I was
Yes.
just saying. Okay.
Yep.
Thank you.
Okay, thanks. Are you okay with questions as we go, or do you want to, would you rather do the presentation and then ask questions? It is completely up to you.
Really preference to the committee. I'm fine with either.
Okay, and I want to make sure we get through the presentation, so as normal, I may redirect us slightly. So, okay, keep going.
All right, so this next slide shows some of our syndromic surveillance data that looks at suicide-related ED visits, emergency department visits. From this data system, the earliest data that we have is 2017. This graph shows both the number of suicide-related emergency department visits and then the rate of visits expressed as 10,000. We use this often in our analysis to help adjust for different population sizes. As you can see here, that the rate of suicide-related ED visits has increased over this 6-year period, where both the number and the rate of suicide-related ED visits was highest in 2022.
So I'm sorry, rate per 10,000 versus the number, so the bottom number is the number of suicide-related visits. Okay, thank you. And then the top number is the rate. Thanks.
Okay, go ahead.
Let's do a couple slides and then we'll come back.
Suicide-related visit was.
Okay, well, no, that's a good question. Yeah.
Great question. So a suicide-related visit is an emergency department visit either for suicidal ideation or self-harm, or it could be a combination of both of those
Look, can I
things.
ask you a question about the self-harm? Somebody cuts their wrist or a cutter. I've heard that term used, cutter. Is that self-harm that relates to suicide?
It may or may not be,
Oh, okay.
but yeah, intentionally cutting yourself would be reflected in our data for intentional
It would
self-harm.
be, so it would be in this data.
It would be in this
It
data,
would
yes.
be.
Yep.
Okay, got it, thank you.
Okay, thank you.
This slide shows who is being impacted most by suicide and self-harm. The graph shows the rates of intentional self-harm and suicide by age and gender. For suicide deaths, we see the highest rates among those that are 25 years and older. We also see that males have a suicide death rate that is 4 times higher than females. For self-harm, the highest rates are seen among those who are 15 to 24 years of age. And females have a self-harm rate that is nearly twice that of males. So as you can see, for suicide deaths, it's an older population in males, and for intentional self-harm, it's a younger population in females. Now we're going to shift briefly and talk about means. Means look different for both morbidity and mortality.
Okay, no, go ahead. Go ahead.
Among those who have died, we see that over half of people used a firearm. 24% of suicide deaths died from suffocation or hanging, 18% poisonings, and the remaining groups had lower frequencies. Our morbidity data shows that nearly half, or 48%, of intentional self-harm visits for self-harm are poisonings. Poisonings includes things like intentionally taking too much substances like prescription medication, over-the-counter medication like Tylenol, household substances, and also includes carbon monoxide poisoning. The second most common form of self-harm is cutting. And this would be intentionally cutting oneself with a sharp object. And then the remaining forms of self-harm occur at much lower frequencies. So this past year, we have produced data briefs on populations who experience high suicide morbidity or mortality. So far, we have looked at these 4 populations. I'll summarize some of the key findings here and risk factors, but I encourage you all to check out each of these data briefs for more information. They're at the end of the slide deck. The 4 populations at high risk that we've explored so far are men, rural Vermonters, Vermonters who identify as LGBTQ or plus, and Vermonters living with a disability. As we saw earlier, males have high suicide mortality. They represent 80% of deaths in a given year. Most males who die or think about suicide are white, non-Hispanic, have a high school education or less, have been never married or divorced, or have poor physical or mental health. Among males who think about suicide, some of the common risk factors that we found reported included experiencing housing instability in the past 12 months, delaying a doctor's visit because of cost, or living with a disability. We also know that 41% of males who died were experiencing a crisis in the 2 weeks preceding. The most common type of crisis we saw was a crisis related to an intimate partner, which includes things like a partner asking for a divorce, a fight or breakup, an assault, or being involved with a relief from abuse order. Other types of crises noted included having a criminal legal problem, a mental health problem, physical health problem, experiencing eviction, or a job problem. Rural Vermonters comprise 80% of Vermont's suicide deaths. In this context, we define rural as a resident who lives outside of Chittenden County. Some of the risk factors that we found among rural suicide deaths include using firearms as a means, and then we also found that rural suicide deaths have lower rates of mental health diagnosis and treatment compared to urban suicide deaths. People who identify as LGBTQ or plus experience high suicide morbidity. Some of the factors that we found among LGBT youth that are elevated include things like depression, intentionally hurting themselves, being bullied, misusing prescription medications or other substances, experiencing dating violence, and LGBT youth who made a plan are much more likely to engage in these or have these risk factors compared to students who have not made a suicide plan. They are also less likely to experience protective factors like feeling like they matter in their community. Another population that we actually recently learned about who experience high suicide morbidity are adults that live with a disability. Those that live with a disability represent 61% of adults who seriously considered suicide in the past year. We've also learned that those with a cognitive disability may be at greatest risk for seriously considering suicide in Vermont. And then we have found that the more disabilities a person has, the more likely they have also considered suicide.
So your definition of rural was people who live outside of Chittenden County, but there are parts of Chittenden County that are rural, and then there are plenty of places outside that are urban, like Rutland or, Brattleboro or St. Johnsbury. I was just wondering, okay.
Yeah, so there's certainly a lot of different ways to define urban versus rural. For the analysis that we did, we looked at just county of residence.
Okay.
Can I just clarify? So it seems like of your 4, so you're looking at the actual suicides, completed suicides with male and rural, but you're looking at suicide attempts or suicidal ideation with the bottom 2.
Yes.
Okay.
So males and rural Vermonters have high suicide mortality. We know that from our data. From our morbidity data, we've learned that LGBTQ adults and youth and also Vermonters living with a disability have high suicide morbidity. And in this instance, they are more likely to plan suicide. Okay. I also want to talk about another high-risk group for suicide, which are veterans. Veterans comprise 18% of suicide deaths a year on average. You can see over the 5-year period, the number of suicide deaths among veterans has fluctuated, but in 2021, we did see the highest number of deaths that we've seen in the 5-year period shown. The rate of deaths for veterans in 2021 is also much higher than the rate of suicide deaths for non-veterans.
Do we know what the national average for the veteran rate is?
I don't know that off the top of my
Okay.
head. But I can get back to you with that. So I also will show some trends in firearm deaths now. So this slide shows the number and rate of deaths from firearms from 2012 to 2021. The number of deaths are in orange and the rate of deaths is in the blue line. As you can see, the numbers have fluctuated a bit over the past 10 years, but there hasn't been any statistical changes. And then you also see with the rate of death that there's been even less variation and also no statistical change over time.
So, just thinking back to the slide earlier about our increasing rates, so you would think that the increases are due to other means? That could be said?
So it's just that the overall suicide rate is increasing.
By other means, though, if the firearm rate is staying steady.
So firearm deaths include suicide deaths and then also deaths from other intents. So I would look at them separately.
Okay, I'm not sure I'm understanding, but I'll talk to you later.
Okay.
It's flagged that to come back to. Maureen?
Hi, can you give a number to that when you say no statistical significance? Can you give a number to that? Either like, is that margin of error? Is that?
Could be a margin of error. It could be because the number of deaths are relatively small. So with statistical significance, you need to see like a significant change in both the number to be able to detect a
Above a
change.
certain percent? Is it percent or?
So it would be, you would have to, sorry. You'd have to see a large enough change to be able to detect for statistical significance.
That just has to do with numbers, right?
Yes.
I mean, that's,
Yeah.
do you want to?
You want me to?
That'd be great, yeah. That would be great.
I
if you can.
apologize, I was looking for a number, but I realize it's hard to just
So
pull it out.
statistical significance depends on the number of people that you're looking at. So the smaller the number of people, once you start dividing that population, the wider what we call the confidence interval, right? And the confidence interval basically says, we can say with X amount of confidence that the real number goes between this number and this number. And when those confidence intervals overlap, they're not statistically different because they could be within those ranges, right?
Yeah, but this sample sizes and number is pretty small.
Because this is so small, at about 100 and under, it's like a 10%
Okay, that's.
overlap. So you don't see as many statistical significant differences. Whereas if you have 1,000 or over, you're looking at like a 2.5%. So you're more likely to see statistical differences.
That's helpful, thank you.
That's just part of our fairy dust.
Yep, I love statistics, so thank you, that was helpful.
And a lot of us don't, so that was good. All right, Caitlin.
Okay, all right. So this is actually the last slide before I turn it over to Nick. So here we have firearm deaths broken down by manner over a 10-year period. As you can see across years, suicide comprised anywhere from 85% to 91% of deaths. Homicides represent anywhere from 6 to 16% of deaths, depending on the year. And the percentage of deaths that are due undetermined, unintentional, which includes accidental, or deaths from legal intervention represent a very small proportion of firearm deaths.
So before we turn it over to Nick, I want to go back to the question that Leslie was asking. So I want to make sure we all understand this.
I think I was conflating visits and deaths, and I went back to the slide 4, and that's where I got stuck. So I think I was comparing the wrong thing.
Okay. And so that's helpful. And then I just want to be clear that although the slide says the firearm deaths have not significantly changed, they haven't. But firearm deaths have increased over time.
In terms of the raw number that
Yes.
you're looking at, 56 is certainly lower
Larger than 83, yes. So that's the,
Statistically,
right.
those stay within that.
It's right, because as the overall suicides have increased, fire methods have increased, but
Well,
statistically,
Firearms
Yes.
as a means,
As a
is
means.
large part of suicides. When suicides increase, the proportion of either firearm deaths, they all
okay,
move it together.
great. Not great, but thank you for explaining that.
Yeah.
Okay,
So could we go back just for a second to slide 4? Do we know how many of those visits are related to firearms?
So there was an analysis that I did this year looking at male suicide-related ED visits, and fewer than 6 of those visits involved a firearm.
Fewer than 6 of the 56.
So that's overall, that would include both males and females. But it would be, males are 50, around half of the visits are males, 40 to 50% of suicide-related visits are males, and fewer than 6 of the male visits were for firearms.
Jen.
I was just going to say there's some thoughts and research around lethality. While we see a large proportion of suicides due to firearms, there's not a lot of visits.
I was wondering that. They don't make it to the ER.
Yeah, there's some stats that kind of, go along with that in terms of when people attempt with a different method, most of them don't go on to die by suicide. But if you're attempting with a firearm, you're most likely to complete.
Right. Does everyone understand that? That's a really key point.
That was my question too, so I don't need to ask it now.
Okay, so we're good. Okay. Thank you.
So I'm going to turn it over to Nick.
Great.
Good morning, everyone. Can you hear me okay?
We can, thank you.
Great. So, Madam Chair, members of the committee, thank you for asking me to speak today. For the record, my name is Nick Nichols. I'm a suicide prevention grant coordinator at the Vermont Department of Health. And today I'm going to be talking about some different grants and programs that are funded or managed under the Department of Health. And just to be clear, are you able to see me or are you just looking at my slides? Just
We can see you and the slide.
Okay, perfect. Excellent. All right. So I just wanted to set the stage around a couple of things which I think that's important and helpful for the committee to understand. And, when you think about suicide prevention, it is both a mental health issue, but it's also a public health issue. And you're going to hear about programming that's available both through the Department of Health as well as the Department of Mental Health. And that's actually a really good thing because we need to approach this issue both from improving mental health treatment as well as approaching this issue from a public health perspective. So I'm going to talk a little bit about how we approach suicide prevention from a public health approach. Great. So, as folks know, public health basically means it's the science of protecting and improving the health of entire populations and communities. And this approach is especially important for something like suicide prevention because we know a lot of people who are at risk do not seek help. And one of the stats that I often will cite is that of the people who die by suicide every year, only about 37% of them on an annual basis are actually actively engaged in mental health treatment at the time of their death. And to me, that means that we have a lot of people who did not ask for or seek help when they were struggling, or they weren't able to find the help that they needed. And so because of that, we need to look at expanding our suicide prevention efforts, not only to improve our mental health treatment system, but also to work with broadly across our community authorities, as well as our healthcare sector and the general public to engage everyone in suicide prevention. And I just included a quote we have here from our public health campaign around suicide prevention, which kicked off this fall. It's under the moniker Facing Suicide VT. And our theme really is that all Vermonters have a role in facing suicide. And so as you'll hear, a lot of our work through our Department of Health activities are focused on engaging with anyone we can across Vermont to focus on suicide prevention. So you can go to the next slide, please. I also like to pull up this slide and graphic just as an example for people to understand that suicide prevention is actually, it's a complex set of different strategies. And so when you hear about all these different programs and partners, the reason that there are so many different organizations involved and it's happening in so many different places is because there are actually quite a few different strategies and evidence-based approaches to doing suicide prevention. And so as you're approaching suicide prevention from a state level perspective, ideally you want to be focused on addressing all of these areas as you work to do suicide prevention, because they can all play a factor in reducing suicides. And so, for example, as you look at this chart, you'll see some of these examples are specific to the mental health treatment system, improving effective care, doing a better job responding to crisis, and then also improving care transitions and linkages. But you can also see that there's areas that focus more broadly on our population. For instance, doing a better job identifying people who might be struggling and assisting them wherever they are. And then also encouraging help-seeking behavior. And so any Vermonter that might be struggling feels okay asking for help. And then also we want all Vermonters to be in a position where if they feel like they're worried about someone, they know how to reach out and support that person. We also know that doing things like reducing access to lethal means reduce the risk of suicide death for people who are at risk for suicide. And so there's a whole set of strategies that you can do just focused on reducing access to lethal means. We also can do more upstream activities like help people develop their life skills and resilience, as well as increasing connectedness. We know those are all protective factors for people in reducing suicide risk. And then lastly, for people who have been affected by a suicide loss, we know that they themselves are at an increased risk for thoughts of suicide because of that experience. And so we need to increase our post-vention support for people who have been affected by a suicide loss, and both to better support them and also reduce their risk of suicide. So next.
Nick, we do have one question.
Absolutely, go for it.
Daisy.
Hey, Nick, it's good to see you. Thanks for joining us.
Absolutely.
You can just quickly talk a little bit about the importance of care transitions and what you mean when you say that.
Absolutely. Yeah. Sorry, I kind of breezed through that really quickly. But, essentially, if you think about someone who might be struggling with suicide, there's different levels of care or different mental health programs that they might end up in. They might be identified when they're at a primary care practice. They might go to the emergency department. They might go to a more intensive mental health treatment program. And as people are identified and you realize this person needs support, one of the things historically that has happened is that person gets handed off or moves to another level of care. Many people fall through the cracks. They don't end up where they need to be. They don't follow up on their appointments. Or information that's collected by one treatment provider doesn't necessarily get transferred over to the next program. And so the next program actually doesn't have all the most important information. And so ideally, you want an entire system that's communicating with each other and making sure as people are moving through these different programs, they're being followed closely and no one falls through the cracks and they continue to be followed and also getting the right level of care depending on the level of risk. So I hope that helps.
Thank you.
Great. Thanks, Nick.
Absolutely. And I know Department of Mental Health is going to talk a lot more about the zero suicide model, which that's sort of a key component of its focus. Okay, so for the Department of Health, we actually have three primary grants or sources of funding that are supporting a lot of different strategies that fall under those various categories. We have a federal grant from the Centers for Disease Control and Prevention called our Comprehensive Suicide Prevention Grant. We also just received a youth suicide prevention grant from the Substance Abuse and Mental Health Services Administration. It's called the Garrett Lee Smith Youth Suicide Prevention Grant. And then VDH also uses some of our Title V maternal and child health block grant funding to support various youth suicide prevention activities. So I'm going to talk about each of them really briefly just to give you a snapshot of what's happening. So next slide, please. So the first grant I'm going to talk about is our Comprehensive Suicide Prevention Grant. That's a grant from the Centers for Disease Control and Prevention. We received that grant in September 2020, and it's a 5-year grant. Though I would say because of COVID, our launch of that grant really was delayed until the fall of 2021. And so we've really, when you look at the activities, we've really been actively implementing that grant for about a year. For that grant, we're primarily focused on supporting a 10% decrease in both morbidity and mortality among Vermonters ages 15 to 64. And we're also hoping to expand our prevention to several different focus populations that are experiencing disparities, both for suicide, morbidity, and mortality. And Caitlin talked about those in her slides. As I talked about before, through this grant, it allows us to do a broad set of public health approaches to suicide prevention, which means implementing programming across community programs, working with employers, businesses, healthcareers, as well as the general public. It's also allowing us to increase overall public awareness around suicide prevention resources, which also hopefully helps increase access to suicide prevention resources. And then, as with all of our activities, a lot of this work is co-managed with the Department of Mental Health. And so even though the grant sits within the Department of Health, we actually meet weekly with several folks from the Department of Mental Health, and they help us co-manage this grant. So next slide, please. So this is a lot of detail, and I apologize for throwing all of this at you, but I just wanted to highlight some of the different strategies that are funded under this grant, just so you're aware of what's happening. This grant allows us to have a very strong focus on improved data surveillance. Caitlin's position is actually funded 100% through this grant. And through that, she is able to produce a lot of very useful data analysis, which helps guide and prioritize the work that we do. This includes things like monthly suicide reports. She's been doing a number of different population data briefs, looking at different groups of people who are greatly more affected by both either suicide deaths or thoughts of suicide. And then she's also undertaking a very large project called the Suicide Data Linkage Project, which is a little similar to the overdose social autopsy analysis that occurred previously in the state, pulling together data sets from a broad set of public and private entities, looking at the types of services that people might have received during the 2 years prior to their death. We're also using this funding to expand what we call suicide awareness trainings. This is our focus with that is looking at who are the various community programs and leaders throughout the state who are not mental health programs necessarily, but might be in a position to recognize when someone they're working with is struggling with thoughts of suicide, and then teaching them how to identify and support those individuals. And there's a number of different training models that you can use when you're doing suicide awareness. And so I've highlighted some of the different training models we have here. We also have a strong access on reducing access to lethal means. This is including supporting healthcare providers on knowing how to do things like counseling with their patients, on access to lethal means, talking to them about access to things like firearms and medications if they're at risk for suicide. And then it also means that we're able to do broad promotion of safe storage, because we know that when households safely store things like firearms, you reduce the risk of both intentional and unintentional harm through a firearm. We're also doing a lot to expand supports for various occupations in the state that we know have higher rates of suicide deaths. This includes first responders, farmers, as well as construction workers. And so we have separate initiatives focused on all three of those programs. Next slide, please. We also have a strong focus on improving what we call postvention response. This is support for people who have experienced a suicide loss. We just completed a statewide assessment looking at current capacity and gaps in the state, specific to supporting people who have experienced suicide loss. And we're using that to plan out various statewide trainings, as well as promoting improved guidelines and resources for how first responders work with people in the immediate aftermath following a suicide death, and also coordinate with mental health crisis. We're also able to use funding to implement suicide best practices within healthcare settings. And so we have a very active project working with all 14 of our hospital emergency departments. They're all involved in an ongoing QI project, which has included training their staff on counseling to access to lethal means. And then we're also partnering with the Department of Mental Health and the Blueprint for Health to do a project focused on primary care, implementing zero suicide best practices. We're also hoping to increase access to mental health care using things like telehealth. And so we've been sponsoring training for our private counselors throughout the state, helping them feel more comfortable working with people who are experiencing suicide through a telehealth setting. And our hope is that, for people who live in rural settings who may not have easy access to a counselor in their region, they can use telehealth to get evidence-based treatment for suicidality. And then lastly, as I mentioned before, we have a broad public health campaign. It's called Facing Suicide VT. It includes both a website as well as lots of social media messaging. On the website, it's sort of the go-to place for people both who are looking for help, as well as if you know someone that you're worried about, it's a place you can find a lot of strategies and education around how to reach out and support someone you might be worried about. It also includes already a lot of resources on how people can get involved in supporting suicide prevention across the state. And then lastly, as a way for us to destigmatize the issue of suicide and hopefully make it feel more okay for people across the state to ask for help if they're struggling, we have a number of stories of Vermonters who have volunteered to share their own ways in which they've been affected by suicide. And so the website includes multiple stories of people talking about how they've been affected by suicide and the importance of talking about it with other people.
So Nick, I'm going to stop you right there. We have a question.
Absolutely.
Art?
Yes, thanks, Mr. Nichols. What you're presenting is very informative. Your first bullet on this plan, the improved postvention response. When a family experiences suicide within their family, is there an automatic connection from someone to that family? Is it automatic, or must they reach out for it? Does someone get a hold of them? I'm wondering.
Yeah, that's a great question. And it's something that we really dug into as part of our statewide assessment. And what we found is that there's actually quite a bit of variability around the state, depending both on the resources and the degree to which first responders coordinate with mental health crisis teams. And then also, we found that, in some cases, people don't have the appropriate resources to share with families. And so in some cases, I think you would find that in certain parts of the state, there is an automatic follow-up and that families are getting the right resources. Mental health staff or programs like the American Foundation for Suicide Prevention are following up with those families. In other cases, that's not happening. And so part of our goal through this grant is actually to set up best practices throughout the state on how the best way to make sure that families are offered support at the right times. And, it becomes especially complicated in certain situations because some families don't want to talk about it or engage with anyone immediately after the death, but they may be ready or interested 2 weeks or a month or 6 months. And so having an appropriate set of ways to reach out and offer family support in a respectful way is really important. And that's one of the things that we're going to be working on in the coming years. So it's a great question, though.
Yeah, I think that's a real important part of the strategy right there. Thank you.
Absolutely.
So Dane has a question, and then Alyssa.
Thank you, Madam Chair. Thank you, Nick, for presenting. I have a question about the previous slide. And it was one of the supports for at-risk occupations, the mental health and overdose prevention for construction.
Yeah.
I remember from the social autopsy that was put out there, it was pretty remarkable, the risk factor of having an occupation in construction and how much more likely that would kind of indicate that somebody could be at risk of fatal overdose. So could you just talk a little bit more about this project?
Yeah, absolutely. This is it's a brand new initiative that just kicked off in November. But as we were, as Caitlin and our team were looking at different occupations that were, having higher rates of suicide deaths, we found that people working in construction had much higher rates of suicide deaths compared to the general public. And the value of being within the Department of Health is that our project is sort of sits next door to the Division of Substance Use Programs. And so given that we had also heard that overdose rates are also much higher for people working in construction, we reached out to that division and agreed to co-fund a year-long pilot working specifically with construction companies to connect with them and come up with different strategies to get resources to their employees, both about taking care of their mental health, as well as how to access supports around substance use, and also just being more aware around issues like suicide prevention and how to support each other. And so, I'd be happy to come back and talk for an hour about this, but, in a nutshell, we're going to be working with Vermont's largest EAP provider, InvestEAP. And through that program, through this pilot, they're going to be offering a free year of EAP services, employee assistant program, to any construction company in the state that does not currently use EAP services. And so the construction workers for that year will have free access to both mental health and substance use support. And then as part of that agreement, we'll also be going in and providing training and resources to the construction workers, specifically on mental health. And we actually have our first training planned with PC Construction. We're going to be doing a training, hopefully with over 100 contractors and workers from PC Construction in May. So we're very excited about that and think it's going to be a really effective way in connecting with people working in construction.
Thank you.
Alyssa?
Hi, Nick. How are you?
Hi, I'm good. Good to see you.
You too. I just wanted to follow up on Art's question just a little bit deeper. I'm actually wondering, right now, do we know how many survivor support groups are? And also, do they have capacity? Because I know that they had, several years ago, there were long waiting lists to even get into a support group. Do we know what we have around the state in that regard?
Yeah, that's a great question. I actually have a slide specific to that question towards the end of my presentation. Do you want me to respond now or wait till I get to that slide?
I should have looked ahead. We can get to it when you get to it.
Okay, yeah, it's a great question. And it's actually complicated. It's more complicated than you would think. But yeah, I can make sure to talk about that a little bit. It's a really important question. Absolutely.
So, and Nick, I just want to level set time. So I know there's going to be a couple questions at the end. So, and I want to make sure Department of Mental Health has some time to do the presentation.
Yeah.
So let's maybe move through the next ones pretty quickly, 5 minutes or so, and leave, another 5 minutes for questions.
Okay, great. I can go as fast as you need me to. So
thank you.
So let's go through. Okay, so I don't need to go through these, but just in case you're interested in some of the outcomes that we've achieved over this past year, check out this slide. We've had a lot of great, initial results. A lot of people are really supportive and interested in participating in the grant, so we've been really happy with that. So next slide. So I'll just talk briefly about youth suicide prevention. We were also very happy to receive a federal grant from the Substance Abuse and Mental Health Services Administration focused on youth suicide prevention. This is a Garrett Lee Smith Youth Suicide Prevention Grant. We just received it this fall, and so we haven't really kicked off any of the activities, but this grant, similar to our CDC grant, it's going to be focusing both on broad set of youth, ages 10 to 24, but also looking at various populations that are have higher disparities of suicidality, and expanding programming for them, and then working across a broad set of programs, schools, youth programs, mental health and healthcare, as well as juvenile justice. And then as with our other grant, we're closely coordinating this with the Department of Mental Health. So next slide. Just this is if you're interested in knowing more information about what's being planned with this youth suicide prevention, this just lists some of the strategies and programming that will be rolling out with that youth suicide prevention grant. So next slide, please. So I did also just want to briefly mention that, within the Department of Health, we have a Division of Maternal and Child Health. They also have had a longstanding priority focus on youth suicide prevention. They have a Title V maternal and child health block grant. And under that block grant, they include a priority on youth suicide prevention. And so they've been using that funding to support various community programs to do both, helping support various protective factors that relate to youth suicide prevention, as well as addressing risk factors. So next slide, please. And then they're also actively involved in a number of different current programs and councils working to address the issue of suicide prevention. Things like the Child Psychiatry Access Program, which is helping to improve access to child psychiatry for pediatric practices around the state. And then also, as you may know, the Child Fatality Review Team is supported and housed within the Division of Maternal and Child Health. And as part of their work, they do look at youth suicides and came up with several recommendations around improving youth suicide prevention as part of their annual report. So next slide. And then going to Representative Black's question, in terms of what supports are available for families who've been affected by suicide, we did just complete a statewide assessment. And we found that there are definitely, a reasonable amount of supports that are out there. Through the American Foundation for Suicide Prevention, they've helped develop and sponsor multiple support groups. At this time, 4 counties have ongoing loss support groups that are available. The complicating factor is that, some of these support groups also support virtual involvement. And so even though, someone may live in a county that doesn't have its own support group, we do think some families are accessing support groups virtually through some of these other groups. But we had a really hard time, and, we spent a lot of time talking with AFSP about this. We're still trying to determine, do we have enough ongoing support groups in the state or not? And, the general sense is that we absolutely need to be training more people to be able to provide support groups. And over this coming year, we're going to be looking at, are there ways that we can both promote and advertise the existing support groups and make them more available. And then we did also find that a lot of our designated agencies and hospitals, at least some of them, also provide their own loss or bereavement groups as well as counseling. But it's not necessarily available throughout the state. And so there, kind of a similar thing. There's some capacity, but there could be a lot more. We also found that there's actually a fair number of grassroots informal loss groups, which are situations in which a family member who's experienced a loss just informally reaches out to another family and has their own informal group. And we weren't able to gather a lot of information because those were informal, but it was nice to see that Vermonters were taking that upon themselves to offer support to each other. So it definitely, there's a need for more of that. And in the coming years, we're going to be working to, figure out exactly what parts of the state do we need more support groups. AFSP is also very interested in developing more capacity to one-on-one bereavement counseling, in which family members get a very specific training, which allows them to reach out and do a little more one-on-one support of other family members. And so that's also something that we may be bringing to the state. And then lastly, as we talked about before, we did find that there's a lot of areas for improvement following the aftermath of a suicide death, and improving how our first responders both provide support and then coordinate with our mental health crisis teams to make sure families are getting the right kind of support at the right time. And, as I mentioned, both of our federal grants have a focus on postvention. And so we are going to be putting some funding into doing more training to help expand capacity around different kinds of bereavement, as well as something called the Finding Hope support groups, which is actually a support group model for families who have a youth who's struggling with suicidality. And so we're excited about expanding that. So I think I'll stop there. And if there's time for more questions, I'm happy to take them. Otherwise, thank you so much for inviting me. And I'd love to come back anytime, or just let me know if you have other questions.
Great. Thank you, Nick. Yeah, I want to make sure we have time for questions. So I know we have Brian, Alyssa, Mari, and Topper.
I saved my questions for the end, so you might need to rewind. But there's a slide that showed suicide in Vermont. I think it was your first slide. And it talked about emergency room visits and deaths and attempts. And what I'm wondering is, this slide is showing the hospital visits, emergency room visits. I'm wondering if there's any idea what percentage is not being recorded. In other words, like how many people are struggling who are not going to the hospital or emergency room, or who have a suicide attempt and don't get treatment but live, because I have experience as a clinician with people who have tried many times before they actually ask for help, and they live and they get through it somehow, they heal or whatever. They don't actually die from the overdose, et cetera. Do you have any idea what the bigger, what percentage?
Don't know. Yeah.
But that's a good point, is that there are people that we're not capturing in the data, right?
And I guess I'm wondering what the scale is, because my qualitative experience is that it's a lot bigger, but I don't know with I just don't know how you measure that or even begin to assess how big the problem is.
So we ask in the suicide attempt number that comes from the Behavioral Risk Factor Surveillance System, which is an anonymous adult survey every year that's done in Vermont. And in 2018, we asked the question, have you attempted suicide in the past 12 months? And from asking that question in 2018, we were able to derive that 1,900 adults attempted suicide in the past year. So we have some information from our adult surveys, but in terms of like ongoing surveillance efforts, we're not asking every Vermonter every year, have you attempted suicide?
What about, I know that crisis services keep a lot of data around the content of calls, like when someone calls and they're counseled over the phone. Might there be a way to use some of that data to get a sense of how many people are actually struggling with suicidal ideation?
Mm-hmm.
Okay. So the other question is, and the reason I'm asking is because I think the problem's bigger than this, and I think it's important people recognize that. So then the other question is, it's population specific question. So I'm just trying to find the page, and I'm sorry, I saved them all for the end because I didn't want to interrupt you. So, so this is page 7, and there's 2 groups I want to ask about. One is LGBTQ+. I'm curious, what role does access to gender affirming care play in suicide rates for LGBTQ youth?
I don't have an answer for that. Don't know.
Okay. Then the other question, so this is veterans. Do we know when you compare, it's the next slide, when you compare the rates of percentage of suicides per veteran versus per cap. Oh wait, I think it says it right there. Never mind. Now I see it myself that I looked at it again. Moving on.
On the slide.
Yeah, because it says 23.7. So I wanted to compare those two, and you can see there that there's a dramatically bigger.
And then I also was able to find out the national veteran suicide rate is 16.8. So in Vermont, that rate, our veteran suicide rate is much higher.
Okay, and then the last question is that it's the slide before about Vermonters with a disability. Mm-hmm. Do we know what role chronic pain plays in suicide?
Good question.
Would you repeat that, Brian?
What role does chronic pain play in suicide? Just because like disability is one thing, but then there's like there's another layer, which is if a person's ability is confined, it might affect their feelings, but then if they're actually in pain and their abilities. So I'm just curious if there's been any data on that or.
So the disability, this data comes from the breakfast data, which I spoke to earlier. During the years that we've asked about suicidal ideation, we have not asked about chronic pain, so I wouldn't be able to have that answer.
And if it's fair if you don't have the answers, I think these are things I'd like us just to consider more, you know.
Yeah, no, you raised really good points. Alyssa?
A couple of questions. So pertaining to this slide and also one of the slides that Nick had, males, 41% experiencing a crisis at the time of death. And then, Nick, one of your very first slides was the public health approach, talking about people not seeking help. And I'm wondering, are people not seeking help because there is a cohort that are not having an issue with mental illness or their mental health? Where it's, if 41% are experiencing a crisis at the time of their death, maybe there's no help to seek because there's nothing wrong. Does that make sense? Up until that crisis and up until that moment, because we do know that suicide is a really impulsive. Can be. So I mean, I guess I'm just, are we?
I would leave it at that.
Okay, I'll leave it.
Or Caitlin.
Thanks, because I couldn't get it anywhere else.
I think they get the idea.
Yeah, so I'm happy to give my thoughts about that. Yeah, I think, you know, there are people who experience some type of crisis and then feel like there's no way, sort of, you know, they get to a point of desperation and they choose to attempt to take their life. But there are also, you know, people who are living with depression or just general desperation or lack of hope over a very long time. And so they may not in a moment be experiencing a crisis, but get to the point where they feel like, I just, you know, I've had enough, or I don't see any other way out. And so they may not outwardly, it may not appear as though they're experiencing a crisis, but they've been living with pain or desperation for a really long time, but for whatever reason, not asking for help. So, I mean, that would my own interpretation of the data is that we have a lot of people who are struggling in silence over extended period of time, but no one's aware. It's not clear that they're experiencing a crisis. And so part of what we need to do through our public health approach and education is find those people and say, like, hey, you don't need to be suffering in silence. It's important that you think about your own mental health and take care of yourself and ask for help. And that's sort of part of what we need to do, is not only be ready to respond to people who are in the crisis, but also find those people who may be struggling for years with certain types of desperation or anguish.
So I'm just going to interject. Yes, okay. So I think that's that focus is needed, but it also appears there is still this cohort of people who it is an impulsive action and they haven't been suffering. And so there is still another cohort of people we need to help in through these various methods that we're talking about. Would that be a fair statement, Nick?
Absolutely. Yeah. You know, and that's the impulsivity of the decision to act on thoughts of suicide. I mean, that's a great way to describe it. There's a decision, and that's why things like safe storage and reducing access to lethal means is so important, because in many cases, those impulses or those decisions, they'll pass, or there'll be more time for someone to notice that the person is in crisis or struggling. And so the more time and space you can put in place between someone and their access to lethal means, it gives you a much greater chance of connecting with that person, supporting them prior to them being able to act on that decision.
Great, thanks. Do you have more?
I want to make sure I heard what you said when you gave that follow-up data. The national average for veteran rate of suicide is 16 point what?
8.
And Vermont is 83.1?
Thank you for clarifying.
Per 100,000.
Yeah.
That's the question for me. What's the denominator?
I did a very quick search on my phone. I don't know what year that 16.1 is from. It should be fairly recent, but it's probably not the exact same year.
Okay.
But it's not like the numbers are gonna come that much closer together.
Probably not. And the denominator for the veterans would be all veterans in the US versus all veterans in Vermont, correct?
Yep.
Yeah, but our rate is,
So the rates are per 100,000 when you talk about the rates of, 20.3? Is that what you're saying?
yes.
Thank you.
And last thing, which is something I think you'll have to get back to me on, and it's more data. I really would like to take this information on your very, very first slide. If we include mortality and morbidity, what percent of suicide completion and attempts are methods other than firearm, and what percentage do they make up of all attempts and mortality? And what percentage of attempts are with firearm compared to the rate of mortality? Because you have you have 51% of suicides. 52%.
Yeah.
So I guess I'm trying to get at, of all of these together, what percent are firearms and what percent is everything else? Who lives and who dies?
For morbidity,
Yeah.
Is that, I saw you
Yes.
taking notes, Alex. Does that make sense?
Does it make sense what I'm asking?
I think just combining the data from
Yes.
graphs,
Yes.
Well, so these are separate groups too. I mean, so self-harm are people who lived, and then suicide deaths are people who died.
Yes.
So 52% of people who died use a firearm, whereas, firearms aren't even represented at all in the pie graph for self-harm.
Would it be like
It was
less than 1%?
it's fewer than 6 hospital visits.
I'll take my question off.
6, okay, because of suppression, but
Okay. She'll get with you all. Mari?
2 questions. One is about the definition of first responder, and tied to my question is my experience as a nurse a frontline nurse having worked through COVID, and knowing, at least anecdotally, it seems like there was an increase in suicidality for healthcare professionals during and since the pandemic. And I completely understand that first responders, if the definition is police, paramedics, EMS, fire, I definitely understand that. But I'm wondering about your definition, if first responders includes healthcare professionals working in facilities or not, and if not, will you look at that?
Yeah, so Nick can speak to the information on first responders.
Yeah, that's a great question. So our work so far has primarily focused on the definition that you gave previously of, law enforcement, fire, EMS. Those are the primary groups. And, part of our reasoning behind that is because, especially for EMS, so many of them are part-time, volunteer. It's a pretty loose association, and so they don't necessarily have a strong network or an organization that's watching out for them in the same way that a large, entity might be. But it's a great question of, are there ways to increase support for broader healthcare professionals who are experiencing their own level of stress and trauma from experiencing those? So it's a great question, and we can absolutely, look at, are there ways to make it more available? So yeah, I
Yeah,
think it's
and maybe even gather data with VAS and other organizations. So thank you, that helped with that question. My last question is, I didn't see any information about racial data until your slide about one of the grants that was focusing on BIPOC. Can you speak to that a little bit? Why don't we have, or do we have current or retrospective data based on race? And what are we doing now about that? I know the Department of Health is definitely working on that.
Yeah, so we do have both suicide, morbidity, and mortality data on BIPOC. We know that suicide morbidity is much higher in BIPOC populations compared to white non-Hispanic populations.
So morbidity, not mortality.
Not mortality, no. Yeah. Topper?
Thanks, Madam Chair. I'm looking at chart number on page 5. And as you went through your presentations, you talked a lot about youth. And before I ask the question, I want to make sure that everybody understands that I think youth, people that aren't considered youth, are equally as important. It appears from the information that suicide, the people that actually die, it's way higher with people 25 up to over 65. And can you just talk about why the emphasis is so high on youth?
Well, so for youth,
prevention,
they have high suicide morbidity. So there's high self-harm rates in youth. Yeah. Whereas our suicide death rates are highest for people 25 years and older, including 65 plus, 45 to 64. Why is there so much prevention activities happening for you?
No, I'm not saying it is prevention. That's the reason why the focus is on youth, as opposed to the focus being on people that are 25 and older.
There's strategies happening for preventing suicide in people 25 and older. Nick, I don't know, do you want to chime in?
Yeah, so between the two grants, our CDC grant is focused primarily on adults. It's sort of ages 15 to 64, but we are including a lot of programming for even older Vermonters. And then the other grant is focused specifically on youth suicide prevention. And part of that also is because for people ages 15 to 34, suicide is actually the second leading cause of death among all causes. And so it is almost, one of the primary reasons that our youth are dying. And so we feel like it's, there are myriad reasons to focus, on different populations and different age groups based on what we're seeing. Hope that answers your question.
Thank you.
All right, we're going to do Daisy. Sorry, Art, we really have to get to DMH. So we're going to do Daisy, and then I'm going to ask for a piece of data, and then we're going to switch to Department of Mental Health. So, and then we'll have a committee discussion, and if we need anyone to come back in for more questions, we will definitely do that.
Okay. One thing I learned from Caitlin and others, including Nick, no one's reminded us yet that suicide is preventable. And so kind of to summarize, I wonder if one of you can kind of just briefly pull this together into who is dying and why. It used to be middle-aged men in rural areas by guns. Is that still the case? Just to kind of pull together all of the demographic data that you showed. Can you articulate that
as to why they're dying?
Well, I guess that's not why, but the means and the demographic data.
Yes, so suicide deaths are largely male, 25 and older in rural areas. By firearm.
So I'm going to follow up real quick while you think about how you're going to follow up on that. And so can we get so there's the chart on page 9 that's firearm deaths. Firearm deaths. Can we get the firearm death data by age? That would be great.
And veterans, I think the other piece of it is what is on the rise, because veterans nationally have been on the decline, is that right? But in Vermont, it looked like they were on the rise.
I can get back to you on that.
Yeah.
Okay, I could be wrong.
I hadn't heard the veterans on the decline.
Okay, I could be wrong.
But it's possible it's true, and I just haven't looked recently.
Okay.
Caitlin and Nick, thank you very much.
Thank you.
Really appreciate it. We will be taking testimony over some time. If we have additional questions, we may reach out via email or have you come back in, but this is really good information. So we are going to quickly transition to, yes, go ahead.
The transition is
Yes.
going.
So Allison, if you want to come up, that would be great.
I think
If you want to be fancy, you can say epidemiologist.
Yeah. Presentation, there is the same on firearms, I might have the firearms in age.
She lives in my,
Okay, great.
she works for Yale.
Thank you for that. And so as we transition, everyone, we're still on live. I just want to remember, but I want to reiterate what Jen it is Jen, right? Okay. Okay. That there are some issue briefs at the end of Caitlin's presentation that would be probably helpful for all of us to peruse. Thank you for including those.
Thank you, Caitlin.
Thanks for making data awesome.
I tried. I understood it. I know I can get tricked up with the statistical significance, so, yeah. This is just.
Christy, big chair.
Oh.
Next hour.
My goodness.
So I just want to set expectations again, watching the clock. We have, our next testimony is going to start at 10:45. And I do want to give everyone a 5-minute stretch break. So again, we may have to limit questions, write them down. This is definitely not the last time we ever have Department of Mental Health in our committee room. So we will bring them back. But I think for quick, very, very quick, because we haven't met Chris yet. Let's do a quick round of introductions. Art?
Yes, Art Peterson from Clarendon. I represent Clarendon, Wallingford, West Rutland, and out of Rutland Town.
Leslie Goldman, Wyndham 3, Rockingham, Brookline, and Westminster, which is the Bells Falls area.
Daisy Rebecca Winooski.
Laurie Cordes, Lincoln, Bristol, Moncton, and Stocksboro.
Topper McFarland, I live in Barrytown, I represent Barrytown and piece of Williamstown.
Lori Houghton of City of Essex Junction.
Alyssa Black of Essex.
Alan DeMar, representing Enosburg and Montgomery.
And Bobby Farley's Rubio, Varnet, Reigate, and Waterford.
Thank you. And for the record, I'm Chris Allen, the Director of Suicide Prevention
Great, welcome.
for the Department of Mental Health.
Thrilled to have you.
And I'm Allison Crump, Deputy Commissioner for the Department of Mental Health. And we're here today to give you an update on what the mental health side of things. I agree with Nick Nichols. This partnership has been amazing and really expanded how we approach suicide. But we'll be talking the mental health side. And one of the first things we just wanted to make you aware of is it's growing how we approach suicide prevention. And this list of partners are integral to that growth. And so you'll just see a few of the different pieces on here. One, I want to note, we're working more with the Office of Veterans Affairs. And we'll talk at the end about the Governor's Challenge for Suicide Prevention, which is focused on service members, veterans, and their families. That's in response to the data that you saw earlier. And just a reminder of what you saw from us last year when we came in and said we really want to do some expansion of suicide prevention. The governor supported that effort and there was a budget ask. And that budget has supported the following things. So we have been working on bringing zero suicide to the state of Vermont. We'll give you a brief rundown of what we mean when we say that term. And we'll try to do that every time because it's kind of a hard concept to grasp. But we really focused on the designated agencies with the idea that if we're going to do a lot of this building awareness to say, please seek help, that if somebody does raise their hand and say they want it, we want to make sure there's someone at the end of that or on the other side of the door that not just knows how to support them, but knows how to support them specifically for suicide prevention. I think that gets at Representative Black's point. This isn't always about depression or anxiety. It's about making sure people understand that suicidal thoughts pop up and how do you address those and have conversations about those specifically. So expanding Zero Suicide trains staff at the DAs. We have been building that over the past 6 or 7 years. We had started with 3, we got to 7 in 2020, 2021, and then this year we're moving to all 10. So that's what that funding expanded for Zero Suicide. We also requested a director of suicide prevention. There's a lot of talk about all the things going on and struggling to coordinate them. And so you're gonna hear from Chris Allen today. And, you know, I think maybe I'll just give him a chance right now, actually, just to tell you where he came from and kind of what he's, you know, he's done a lot of work in the state before he got to this point.
Yeah, so I'll give a quick 30-second elevator speech. Started my kind of suicide prevention journey while I was in college at St. Michael's College. And I founded the Active Minds chapter there, which is a peer-to-peer approach for supporting individuals, educating individuals on providing support or recognizing warning signs. Non-professional. It was working with college students, really enjoyed that. And that's a chapter that actually lives on. Post-grad there, I started working with or volunteering with the American Foundation for Suicide Prevention, was the Burlington Out of the Darkness Walk chair for multiple years, was the board chair of the Vermont chapter, and also was an advocate and was also part of the Healing Conversations group, which speaks to the postvention. And then went back to get my master's in social work at UVM here. I'm now a licensed clinical social worker, transitioned into this role about a month and a half ago after working at Vermont Psychiatric Care Hospital in Berlin for the past 3.5 years.
Great. So I'll be work. Yeah, he definitely brings a breadth to and it's nice that a lot of people in the work know him. So relationships involvement there. Right. And so you'll notice this will be my last slide until the end because we're going to be handing the baton over. You've seen my face a lot with suicide prevention and I'm never letting it go, but this has been an amazing thing to have a full person. And so the other pieces we'll show you today about funding. The expanded funding went to 988 implementation. We'll give you a brief update on the numbers there. I know you've seen them before. We have a few new ones. And then increased funding for outreach to older Vermonters. So yes, the data right now is focused on middle people from 25 to 65, but we've had pockets in the state where there have been times where over 65 were the most acute. And we know in Vermont, the numbers are small enough that things vacillate. So we used funding to support where this group goes out to people's homes and meets the mental health needs of older Vermonters.
Okay, well, yeah, so we'll start with a little bit of an overview of the Zero Suicide grant work. DMH has been partnering with Center for Health and Learning and helping them incorporate Zero Suicide within the designated agencies. They've been doing a great job with the $495,000 that has been allocated to them. Like Allison said, it is now with all 10 designated agencies and the 2 specialized service agencies. So it is statewide. It covers the whole state at this point. So this is just a basic chart of what Zero Suicide is. It has proven effective in other states. It's a framework. It's a way of how someone will work through the mental health system with the appropriate level of support at each level. We want to make sure that people are at the least restrictive level with the best evidence-based practices that we have at our disposal and making sure that the workforce is trained on that, competent in it, and confident with delivering that to the individuals. And then moving along, so this is talking a little bit about the implementation statewide. So the evidence-based practices, we've listed a few of them here in the first bullet point. CAMS, which is Collaborative Assessment and Management of Suicidality. We also have the Columbia Suicide Severity Rating Scale, CSSRS, and then also CALM, Counseling on Access to Lethal Means. CSSRS is used at VPCH, so I have a lot of confidence in this rating scale. And then just looking at some of the newer trainings that have been implemented, following up with care coordination, electronic health records, making sure that we have client level data, which is a requirement of Zero Suicide, and the implementation of that, making sure we're looking at DEI, diversity, equity, and inclusion, having trainings on that. And then also having conversations on suicide, which is more of a peer model. So anecdotally, individuals are more likely to reach out to their neighbor, community member, rather than a professional if they're in crisis. So making sure that the community is aware of the resources out there, they aren't intimidated by that conversation, and then can provide the assistance and referral further on if needed. And then also with that money, there was a Center for Health and Learning does the monthly coalition meetings, bringing statewide partners to talk about their efforts, what they've been noticing, making sure that we're staying up to date on what's out in the community and what they're hearing. In 2022, in November, they held a Zero Suicide Practice Institute. So all the designated agencies and specialized service agencies were invited to that. It was a great networking opportunity for them to hear from designated agencies that are further along in their implementation of Zero Suicide, and also share the learnings, hear from the Wildflower Alliance, which is a peer support group, and also the Director of Trauma and Resiliency for the Department of Mental Health, Kia Ganguly, gave a presentation as well. And then just briefly, the numbers of people that have been trained in these modalities are on the bottom right-hand corner. So that's since the end of the legislative session last year. Okay. So really quick implementation of these trainings, thanks to our partners at the Center for Health and Learning. And then here we're looking at the findings from the Zero Suicide Planning and Reporting Survey. So we had 100% of the designated agencies and specialized service agencies responded to this. This was a way for us to know where each department is at each designated agency and specialized service agency in their implementation of Zero Suicide. So have they not yet begun? Are they partially in place and then fully in place and then broken down by department? So at the highest level of care is community rehab and treatment. Those are the CRT clients. Those are the people that are coming out of inpatient settings. And as you can see, a lot of the best practices are fully in place within the Zero Suicide framework. We have some areas that we can improve here, but really important to see that we have agencies implementing this across their different departments, at least partially. So we already have some buy-in. Now, how can we move the needle a little bit further so that we have leadership on board, making sure that they really see the importance of this at all departments? And then CHL is also working with the Behavioral Health Improvement Institute to make sure that these efforts are evaluated and making sure that there's no gaps and those can be identified and then tackling them. This is the client level measurement that we're looking at for designated agency reporting. making sure that people are going to a screening, the screening is implemented, making sure that if they've screened positive, the assessment has been done within 24 hours, and then making sure that once that has been done, that the suicide plan has been developed within 24 hours as well. So that's how we're measuring the success and implementation of these various best practices. Just wanting to highlight the mini grant project as well, which is.
So I'm sorry, Chris, hold on.
Yeah.
Daisy? I'm sorry, Leslie?
I like being young. So could you just talk about lethal means counseling?
Yeah, counseling on access to lethal means.
Yeah, number 4.
Yeah, so it's an evidence-based practice. It is a way to work with individuals on what lethal means they have in their house, if they have them in their house. So if there's a firearm, where is the firearm stored? Is the firearm stored separately from the ammunition? Where are the pills? Are the pills stored safely? Can someone under 15, 12 access those? Where are they in the house? Do you know where they're in the house? Do you know that your younger person or living in the home, do they know where it is? Those types of things. And it's very kind of formulaic in terms of how you're asking those questions and making sure that there's answers for each of those questions.
Okay, so may I, if I may, so that the red arrows mean what?
This one?
No, on the core measures.
Oh.
You're further along. Yeah,
sorry.
that one. Yeah.
So these core measures are just the measures that we're looking at from designated agencies that they're screening, assessing, and then providing a safety plan for the individuals.
So the red arrows mean you're succeeding, and that there's no red arrow mean it's not being done? I'm just wondering how to interpret that.
Wait, why is there no red arrow in number 4?
These are the 3 measures that we're just looking at currently.
Okay.
Okay, so you're not looking at the lethal means screening yet?
Correct. Yeah. Or that we're asking the DAs to report back to us at this point.
They may be doing it on their own, but you don't know about it. Okay.
Right now, we're monitoring the number of counts of trainings happening, but we don't have a way to collect the data on if that conversation has happened. So that'll be a next step.
Great, thank you. Keep going.
And then looking at the Zero Suicide Mini Grant Project, this is just one of the projects that I wanted to highlight. So it's pairing a designated agency with a patient-centered medical home. It's basically a fancy way of saying that it's a PCP office to develop suicide-safe pathways. So what we want is, speaking to Daisy's question earlier about care transitions, this is exactly what we want. So we want people that are working with designated agencies or working with a PCP office, making sure that there's a suicide safe transition from both ways, and that they're communicating back and forth. So what we're measuring there is what screener was used. Was CSSRS, or was a different screener used? Was a referral made from a DA to the primary care patient-centered medical home? And then was a warm handoff made? So did the nurse or doctor at the PCMH, did they call the caseworker or case manager or psychiatrist at the DA and introduce the patient? And then did coordination with the PCP occur? So were there records or, making sure that there's transparency in that referral, why that referral is being made? Was CALM documented? So counseling on access to lethal means, has that been started? not started, where are we at in that process? And has camps training begun for clinical staff? So these are just outlining the DAs and their respective PCMH that they're partnering with. So round 1 was kicked off in October of last year, and then we're starting round 2 now.
Great.
And this was an opt-in, so not all DAs had to do this partnership. Okay. But we have 7 of the 10 DAs that opted into this. Then we have more interested in the next round.
Great. Keep going. We're gonna have questions, don't worry.
Yeah, so now we'll talk about the post-vention services. So this is what our findings from the Zero Suicide Designated Agency end of year reporting survey. So we noticed that, as you'll see, there's different forms of post-vention service, and then how and where that is implemented at what rate. We have some work to do on this, admittedly, and I'm committed to making sure that those gaps are filled. Just one addition that I wanted to make. I know post-vention was mentioned earlier. NAMI provides a lot of support groups to peers and families throughout the state. Those are both held in person and virtual. If you look at where they're located, they're typically in the central and northern part of the state, not necessarily in the southern part, but as Nick alluded to earlier, if it's held virtually, you're able to join if you're in the southern part of the state, but I think there is a benefit to in person. So
we're gonna hold him.
And just an update on 980. These are the latest numbers that I think last time we came here, we only had to October. So November and December did see in continuing high numbers, which we see as a good thing. People are accessing the service.
Definitely.
And then we wanted to highlight, I'm not sure if anyone's come to the group to talk about the Governor's Challenge for Suicide Prevention. It could get its own hour, as many things could. This was an initiative where nationally SAMHSA has been asking for states to sign on, and we signed on this year. I co-chair that with Monica Hutt and Colonel Paul Rowe. And the 3 of us have been working with a very large coalition in Vermont. It's actually one of the greatest groups. We've got survivors. We have people who have lost their spouses in service to suicide. We have healthcare. And this group is looking at, when we ask the question, well, geez, how many service members, veterans or their families are actually accessing care? You know, we can't answer that question. We don't have enough spaces where we're asking about your status. And when we do, we often just say, are you a veteran? And that's not, it's not broad enough. And there's also what I'm learning a lot about, a lot of cultural distinctions between branches and how you affiliate. And sometimes we as providers can water that down or be ignorant to that. So it's really working on building up our education. So we're heading down to DC in a couple weeks to learn a lot about how to implement and better serve veteran service members and their families.
That's great.
More to come. And this is just the elder care outreach. I spoke to that earlier, but if you have more questions about that, Dale would be a great group to talk to.
Okay. Art?
Yeah, I could ask you questions all day here. This is very interesting and informative. But to be direct, I'm going to slide the post-vention one, 10. Brief intervention support loved ones immediately following suicide, you have 100%. Is that a goal or is that what you're doing? And I almost don't know how you would know about whether a death is a suicide. How does that work?
I can speak to that to just say, this is when the survey is, do you provide it? And so you can imagine the DAs would say certainly, and it is true, when I get a phone call to say someone has been lost by suicide in a region, I'll call the DA, they say absolutely 100%. Do they know about them all? And are families interested in that? Certainly.
Okay.
Certainly not 100% response.
Right. I understand. And the other question I had, this is an overarching question. We heard from the other group just a minute ago. And what percentage of suicides, and maybe this has been put out and I missed it, are people with known mental health versus issues versus folks who just are suicidal? Do we know?
CDC and our state partners do have that data.
68% had a known mental health diagnosis.
What percent?
68%.
68 had no known.
Had a mental health diagnosis.
Had a mental health, so the rest did not,
The rest did not, at some
32%.
point in life. Yeah.
Did not have any.
At some point in life, I want to make that clear. At some point in life, 68% had a mental health
Right.
diagnosis.
Yeah.
Not necessarily at the time that they
Right,
took the
okay.
action.
But
I think
there
that's
was
a
some
really key
history of it somewhere.
Yes.
Okay. All right,
Not
thank you.
necessarily in treatment.
Yep, thank you.
Thanks, Caitlin.
You got a lot going on.
And we have 4 minutes.
Okay. My question is really simple. If your resources were unlimited, where are there gaps? What are you missing? What, in your perfect world, what are we missing? Whew. You had a blank.
I mean, I will say this, human resource. I mean, right now, it's really hard. So we have a lot of regions who would love to have an ongoing group. It's finding the staff who can continuously staff that all the time so that anytime anyone's looking for it, it's available. And it's not just professionals. We certainly need more master's level licensed clinicians, that is for sure. But we also need more human service people in the field, people who are graduating college and saying, I want to do this. Right now, we don't have enough staff. We have people who are in those jobs, do an incredible job and really want to help. They don't have enough people. You know, there's certainly other gaps I think we're noticing here. If you look at the postvention, it's a piece that we've all said out loud today that we're not there yet.
So I want to ask that everyone in the room who's testified consider Alyssa's question. And if there's other things you think of outside, please email us or ask to testify. And I'm going to say that of everyone who comes in and talks to us about suicide prevention. So, Alan.
Do you feel we have adequate prevention measures in our school systems?
I would say likely not at this point. Yeah, I think especially that's an area that we need to really improve on, especially as we're emerging from the pandemic. Youth have been really impacted by the social isolation of the pandemic. And so how are we, and not only has that affected them academically, but also socially and their mental wellness.
Leslie, you got sorry, Leslie, I'm going to go to Dane. Then you'll have the last question.
Mine's really
quick. We have 1 minute.
Yeah, mine's really quick.
Thank you. Just wanted to, I think it was the previous slide about the implementation at designated agencies, or actually the one before that. And it's looking at the, for developmental and intellectual disability services. That looks like kind of the lowest uptake between the different sections, and with the recognition that that was one of the higher risk populations for serious ideation, it just raises some concerns. And I was wondering if you could provide further insight into why they may be slower to uptake these programs and what work is being done.
I could add that one of the things I want to make sure we have a distinction for is the data that Caitlin showed. Disability included physical disability and say chronic pain and more things. This is specific to developmental and intellectual. And so it's a subset of that population. And I do think when we started this process, we went straight to crisis. We went straight to emergency services. And so you'll see the green line on that one is the highest. And it was the last couple of years when we brought in an evaluator who kind of highlighted that very issue for us to say, okay, you're making an assumption that you only need to check suicidality with people who are raising their hand and saying they're in crisis. So it's been fairly new to start expanding. And I think there's some work to be done on the screening tools and the ways we approach for somebody who might have a different developmental issue. So we've got some learning to do.
Leslie?
So I'm just curious about slide 9. As someone who worked in primary care a long time and alongside, mental health support staff. And I was just wondering if you were measuring.
This one?
Yep.
Okay.
Sorry. If you were measuring the time it took from when the referral was made to the contact with the DA, or that gap.
Interesting. So we do have an evaluator of this project, and I don't think that's on there. So I do think that would be, we have in general how quickly someone can access a designated agency, but not specifically for if they're identified at the primary care and referred, when does that appointment happen? That would be interesting to look at.
Thanks.
Thank you, everyone, so much. This was very informative. Like I said, we may be back in touch with you. Committee members,